Hi, Stanton with ACEP Frontline, and today joined by Dr. Matt Fields. If he's looking in your program, it's Jason. As he mentioned to me, he's a middle neighbor. We're talking about some resuscitation, some ultrasound resuscitation. So the Resuscitative Ultrasonography Lab, and we're talking about some of the things that we can do as emergency physicians, community physicians, to add tools to help with our resuscitation efforts. Because as we all know, just looking at sepsis, we have these relatively unfounded rules of just pounding people with gallons and gallons of water and hoping for the best. So first and foremost, give us a little background on yourself.
Yeah, sure. I am the Ultrasound Director at Thomas Jefferson University in Philadelphia. I've been there most of my career. I trained at just across town at Penn, where I did my fellowship, and I've made point-of-care ultrasound pretty much my entire focus of my career. I found it to be just amazing when I was training that, wow, look at the information we can get. We can actually take medicine from a step further by looking inside people, seeing their heart, seeing their lungs, seeing their IVCs, and actually making informed decisions. I became very involved in ACEP. I was the ACEP section chair. I've also been a past president of SAM, Academy of Emergency Ultrasound. But really just love teaching and researching and pushing the envelope with what we can do with point-of-care ultrasound.
All right, so during the length of the tenure of this podcast, we've gone from some of the earlier stages of blocks and FAST and gallbladder and DVT and things like that. But, you know, there was always this kind of this evolution of some of this resuscitative aspect of POCUS.
Mm-hmm.
So kind of get into some of the things that we can do now and how it can assist physicians during their resuscitations.
Yeah, absolutely. So first off, you know, just diagnostically, right? We're talking, if we just start with patients who are in undifferentiated shock, right? Just getting the machine, rolling it to the bedside is going to, I think, for the amount of time you're in the room, you're going to come away with such much more concrete information, just knowing that that heart is either hyperdynamic and beating well, or it's not beating well at all, and you may be dealing with cardiogenic shock. So really helping you differentiate what type of shock, you know, hypovolemic, cardiogenic, obstructive, distributive. You're going to get insight into that right away and really start to focus your efforts. You can do the rush exam, which can actually help you look at, okay, what's the IVC doing? What is there free fluid pooling? Is this kind of a hemoperineum situation? Then you kind of do the high matonomic, heart IVC, Morrison's aorta pulmonary. You can look at the aorta, make sure it's not a ruptured AAA. Look at the lungs, see if there's fluid in the lungs, make sure there's not a pneumothorax. So if you just do that protocol right away, you're getting diagnostic information, but you're also getting some information that's going to help you with resuscitation along the way. You're going to see how that heart's beating. You're going to see where that IVC is. You're going to make sure there's not already fluid in the lungs, so you know you're okay to start giving fluids. And that's going to really, for me, be the start of how I resuscitated the patient. And then you can kind of keep doing serial exams along the way to really see how your resuscitative efforts are taking effect.
So when you look at it, so just say, you know, like me, I'm a community emergency physician. I do a fair amount of ultrasound.
Okay.
But not a ton with regard to the resuscitation. Mm-hmm. If there are a few things like your baby steps, mm-hmm. you know, you've already mentioned some of the exam kind of things to check on, look at. If you could say these are the few things you pick up and you can do it right now and really start to get your foot in the door of resuscitative POCUS, what would you recommend?
Yeah, I think the course that we offer here is a great starter place for people, depending on, you know, how much exposure you've had. If you feel like you haven't had a chance to learn ultrasound in your career, or you learned it, but you haven't been able to reinforce it as much, doing intro course like here at the conference, we do a 2-hour lab session where we go through those steps, those high map steps. Mm-hmm. I think as you mature in your practice, do I go into a rush exam on every hypertensive patient in that order? I don't, because sometimes I'm approaching the patient and my my pretest probability is already for something more like ruptured ectopic, I might skip the heart and and go to those other steps and like looking for free fluid. But I think the rush approach is a good starter protocol for everybody to learn heart, learn IVC, learn the Morrisons or the fast views, learn that aorta view, because you're gonna come across ruptured AAAs and be able to immediately rule in that diagnosis. And then the lung exam is just so easy to learn, and it adds just such another factor. So start with that high map, and then I think there's a lot of places you can go from there. That as technology is evolving, as AI is evolving, a lot of other measurements that we can add on to that as you evolve. But that's where I think I would start.
And we were looking at, early, it was looking at the IVC, of course, looking at the pericardium, CFC diffusion, and those types of things. Now, when we're diving into this, got the rush and high map pulled up here, and how long are we talking about that you need to actually get this knocked out and get that valuable information to guide your treatment?
You mean like in the clinical environment,
Yes.
like how quickly can you step through this? I think once you get comfortable with this, you can. I think the abbreviated, they call it the rush ED or the rushed protocol is 9 views, where it's try to get 2 views of the heart, 1 view of the IVC, then you get your 3 Morrison's views, and then you do your aorta, and then your 2 lung views. So that's like, I think 9 steps. But I think you can actually get through that pretty quickly. I don't, again, we don't need 4 views of the heart to make diagnostic decisions. 1 or 2 good views can tell you right away whether there's a diffusion, whether the right heart's overloaded, whether the squeeze is poor. And then you go get 1 view of your IVC, you take a quick look, and, Morrison's, if free fluid is something that might be in your differential, in your aorta or in your lung. I think it's been studied that the rush protocol can be performed under 5 minutes, in a lot of cases, in the majority of cases, in most studies. So I don't think it's, something that is too onerous to do, especially in these shock patients.
And this one right here, you're talking about here at SA, you and Dr. Avila are talking about, some of these other components as well. You got the rush exam, the cardiac IVC, fast, aorta, lung, and then some vascular access.
Mm-hmm.
To kind of talk about this evolution, continued evolution of POCUS and our role. For me, I feel like that POCUS is an integral tool that not only can we use to more expeditiously get information about our patients, but also the opportunity from us from a reimbursement and financial aspect of adding to our chart abilities, the work we're already doing, and being able to utilize that within our practices. So as the carrot for some of these places that are debating whether they want to dive into the ultrasound world, to kind of get into some of those key resuscitative exams, other than the ones we mentioned so far, and kind of why a community physician may want to really start to pick that up.
Absolutely. And there's been some great talks here at ACEP about billing and reimbursement. So whenever you have critically ill patients, there's some debate about there now with E&M billing. Ultrasound can be used as part of your image interpretation, as part of your EMM billing. And that's really valuable in your lower acuity patients, because you might not be getting any other imaging in those patients, like x-rays or things like that. So you can make ultrasound a part of your EMM billing in lower acuity patients. And then in higher acuity patients, you're usually going to check off that EMM billing anyway, so with x-rays and things. So then you should be direct billing those ultrasounds. If you do an E-fast on somebody, that's 3 CPT codes that can be billed. And if you do more than that, you can add on to that. It really starts to add up. And, there's 2 types of billing. The physician charges for that. I mean, that they will, each one of them, they're not huge, but they add up over time. And especially if you make it just part of your routine. So
yeah, absolutely. I mean, that's what, looking at some of the using ultrasound for guidance or whatever it may be when you look at some procedures. Of course, the additive effect with the overall fast and things that does add up. I mean, we're talking about the fact that we're looking at some of the reimbursement drops. This is a good way to get credit for the work that we're doing and really start to streamline the care while being conserving some of those resources such that they're going to accrue.
Yeah, so many places leave money on the table. I think it's really important that each department takes a look at how they're doing ultrasound and really make sure they have good procedure templates so that they always document appropriately for their ultrasound so they can capture that revenue because you're doing the work and you're providing the care to patients, which you're providing the value and you're providing this expertise that you learn. You spend time taking courses to learn, so you should be getting reimbursed for that.
Our POCUS is relatively mature at this point. We're now probably 20 or so years into significant focus within emergency medicine.
Absolutely.
And where do you see us going in terms of the future? Because now we're talking about, and even machines already are starting to take in some AI technologies, things even further. Where do you see us going over the next couple of years?
So, I mean, that's what I think has been so great for being involved in point of care ultrasound is we feel like the roof keeps going up and up and up. And we have a dilemma in point of care, in emergency medicine, point of care ultrasound is where's the floor and where's the ceiling? When we gave our lecture, Jalen and I gave our lecture, we taught it in a format where we had a level 1 and a level 2 learning. So we started with the core stuff. If we're talking about aorta pathology, we're like talking about, hey, AAA, everybody's got to know that as bread and butter. But look, hey, you can take it to the next level of aortic pathology, and here's how to find dissections, use the suprasternal view to find the aortic arch. And, there's some really cool research that, has been coming out that shows that we can really rule in this pathology. There's the SPEED study that was done where they kind of found a really high sensitivity. If you found an intimal flap, a dilated aortic root, or a pericardial effusion, you can rule that in. So we find that there's, this really big range of things you can learn. You don't have to feel like you need to learn it all. But yeah, it is evolving. We're finding that we can do a lot of cool measurements with doing resuscitation, looking at VTI. Looking at right heart strain and measuring like TAPSE measurements. And Jalen, during our talk, actually introduced something that I wasn't even familiar with, this concept of early systolic notching, where you actually get a higher view of the short axis of the heart and look at flow through the pulmonic valve. And it sounds really hard and kind of crazy, but it actually, she just broke it down in a way that I was like, oh, wow, this is in our wheelhouse. And where I think AI comes into all of this for us is as things evolve, we're going to get a lot of extra measurements for free. We're going to be able to get the on-the-fly interpretations. All we need to do is acquire some of these B-mode images. And, there's technology that's, if you get a good apical four-chamber, or if you could use the heart, not only are you going to get things like ejection fraction automatically, that technology is coming already kind of out there. But they're looking at how with AI, they can detect valve abnormalities with just B-mode images. So no longer are you going to need these patients to maybe even get admitted for formal echoes or for cardiology echoes because you can actually get just a good B-mode image and the AI can actually pick up things like aortic stenosis and things like that. So I think with just getting good B-mode images of hearts, IVCs, lungs, getting some of the cardiac views, we're going to actually be getting all this more data points because of AI being able to do some of these calculations and measurements. And therefore, I think it's going to be on us to know how to interpret some of that data and use it and be able to kind of work with our critical care teams and things like that through resuscitation to see how these kind of these values that we didn't have access to before, just because it was too much for us to do. Now we can actually kind of I think that's going to lead to is refining our resuscitations even more so. I think also AI is going to help us another really important way, and that's going to be with education, helping people to, in the QA process, us be able to, we have too much volume to QA and teach, and I think there's going to be AI tools that's going to actually help us get through more volume of scans that residents are performing and provide feedback.
I feel like in the next few years, our ultrasound machines are going to have to update more than our iPhones just to get with the technology. I mean, just the addition and things that have happened. We're finally got ours that's uploading to PACS, and we're actually able to, from the professional fees and hospital fees to that. I mean, it is a great opportunity. The technology is there. It's going to advance even more, giving us more tools and allowing us to be more efficient with our diagnostics and with our bed spaces and with our resources. How can folks get in touch with you if they have any more questions, want to dive into it anymore?
Yeah. So, I guess my email, is that, yeah, my email is j.matthewfields@jefferson.edu. And, I'm not as social media influencer type, like, my colleague Jalen, who unfortunately couldn't join me, was, but that's probably the easiest way. I'm a kind of old school email kind of person.
I appreciate it. I appreciate you coming in today.
Yeah.
Give us a little background on it, and definitely encourage everybody.
Yeah.
If you get a chance to check out one of these courses here with Dr. Fields and Dr. Avila here at Scientific Assembly, absolutely do it. They are incredible. And not only will it add to your practice, it'll definitely improve your care for your patients as well. As for me, contact me, rstanton@acep.org, at Everyday Med on X. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.